అది ఓకే.
గుడ్ మార్నింగ్ సార్, డేవిడ్ గారు.
దేవుడు బాగా బిజీ ఉన్నాడు.
డేవిడ్ నైట్ డ్యూటీస్ చేస్తున్నాడు సార్.
రెండుసార్లు అవుతుంది అని చెప్తాను.
చెప్తున్నారు
సార్, షేర్ స్క్రీన్ కొడితే అయిపోతుంది. అక్కడ అది ఓపెన్ చేశాను పీపీటీ, అక్కడ స్టార్ట్ అయింది సిస్టమ్.
అక్కడ
ఇప్పుడు యాక్చువల్ ఇప్పుడు మీరు ఇది ఓపెన్ చేయండి. ఇప్పుడు అయితే షేర్ స్క్రీన్ వెళ్తాం.
ఇది రాలేదు కదా,
విన్నాను పక్కన
కనిపిస్తుందా?
ఇది దీన్ని
హలో సార్, వినిపిస్తుందా?
ఎస్ సార్, డేవిడ్ గారు కనిపిస్తుంది.
లైట్స్ కనిపిస్తున్నాయా?
మీరే కనిపిస్తున్నారు సార్ మాకు బాగాను.
లైట్స్
మీరే కనపడుతున్నారు.
లైట్స్ కూడా కనిపిస్తున్నాయి.
కనిపిస్తున్నాయా?
కనిపిస్తున్నాయి సార్. పెట్టండి, స్లైడ్ షేర్ పెట్టండి.
షల్ వి స్టార్ట్?
ఎస్ సార్.
లేదా? హలో హలో.
ఎస్ సార్, చెప్పండి డేవిడ్ గారు. స్లైడ్స్ పెద్ద చేయండి సార్. ఇవి దీనికి వెళ్ళండి, ఫుల్ స్క్రీన్ కి వెళ్ళండి సార్. స్లైడ్స్
ఏంటి సార్?
స్లైడ్స్ ఫుల్ స్క్రీన్ కి వెళ్ళండి అంటున్నాను.
లైట్స్ ఫుల్ కనపట్లేదు.
మరి ఇక్కడ ఫుల్ చేశాను, నేను ఫుల్లే చేశాను యాక్చువల్గా.
అదేదో ఉన్నది సార్, అది ఒకసారి బషీర్కి అడగండి. ఇంత ముందు కూడా నాకు ఇలా జరిగితే ఏదో చేసాడు వాడు. మళ్ళీ డిస్కనెక్ట్ అయ్యి మళ్ళీ కనెక్ట్ అవ్వడం ఏదో చేయండి.
అలా కాదు, ముందు ఫుల్ స్క్రీన్ పెట్టి తర్వాత షేర్ చేయాలి.
అలా చూసేదా?
లేకపోతే ఎడిట్ ఏదో ఉంటే ఎడిట్ కూడా తీయాలి సార్. ఎడిట్ ఆప్షన్ ఉంటే ఎడిట్ తీయాలి. అది మీ సార్, ఎడిట్ ఆప్షన్ ఉంటే ఎడిట్ డిజేబుల్ చేయాలి
సార్. టోటల్ స్క్రీన్ షేర్ చేయండి సార్, పీపీటీ కాదు, టోటల్ స్క్రీన్ షేర్.
సార్ కనిపిస్తుందా? హలో,
ఫుల్ స్క్రీన్ చేయండి సార్.
ఫుల్ స్క్రీన్ చేయండి సార్.
ఇప్పుడు ఫుల్ స్క్రీన్ అయిందా?
అవ్వలేదు. లేదు, అవ్వలేదు. ఫుల్ స్క్రీన్ అయితే మాకు అవ్వలేదు.
మళ్ళా స్టార్ట్ చేద్దాం. టైం అయిపోయింది. ఇక్కడ ఇది కూడా ఏంటి ఎడిట్ ఆప్షన్ కనెక్షన్. సార్ ఇప్పుడు అవుతుందా?
లేదు.
బషీర్ ఫోన్ చేయరా ఒకసారి. అందులో సార్ బషీర్ ఫోన్ చేస్తా ఉన్నాను సార్. చెప్పండి.
ఆల్రెడీ బషీర్ లైన్ లో ఉన్నాడు. డేవిడ్ మాట్లాడుతున్నాడు
సార్.
నాకేం వినిపించలేదు.
వి ఉంది కదా, కనపడుతుంది కదా.
బషీర్.
డేవిడ్ సార్.
ఏంటి అది ఫుల్ స్క్రీన్ రావట్లేదు?
సార్ డేట్ సార్ అది ఒక స్క్రీన్ షేర్ చేసిన తర్వాత మనకి ఆప్షన్స్ వస్తుంది స్క్రీన్, ఇంకా మీరు ఇప్పుడు ఇది పీపీటీ ఓపెన్ చేసినా కదా అది ఆప్షన్, ఇంకా ఏదైనా విండోస్ ఓపెన్ అయితే అది ఆప్షన్ అన్ని ఉంటది. అంటే అక్కడ ఫస్ట్ ఆప్షన్ సెలెక్ట్ చేయండి, స్క్రీన్ ఆప్షన్. ఫస్ట్ ఇది షేర్ స్క్రీన్ ఆఫ్ చేయండి. దాని తర్వాత షేర్ స్క్రీన్ క్లిక్ చేసిన తర్వాత ఫస్ట్ ఆప్షన్ షేర్ అని వస్తుంది. ఫస్ట్
అదే కొట్టాను.
ఫస్ట్ ఆప్షన్
అది
షేర్ అని
హైలైట్
వస్తుంది.
అవుతున్నా, వేరే విండో వస్తుంది దాని మీదకి. అది ఏంటి అసలు, ఏంటో అన్ని షేర్ చేయమని అది జూమ్ మళ్ళా ఓపెన్ చేస్తాం. ఇది కొంచెం
సౌండ్ రాకుండా రెండు కనెక్ట్ అవ్వకుండా ఒకటే కనెక్ట్ అవ్వండి. సౌండ్ వస్తుంది సార్, తొందరగా కనెక్ట్ అవ్వండి, పర్వాలేదు ఏదో ఒకటి. సార్ స్టార్ట్ చేయండి సార్. మధ్యలో వచ్చింది సార్, ఒకసారి మధ్యలో వచ్చిపోయింది. ఇప్పుడు వచ్చింది. స్టార్ట్ చేయండి.
ఫర్ ది లేట్ టెక్నికల్ ప్రాబ్లమ్స్. So we are going to conclude the part 2 of ECG. We have some few slides left in the last slide, last class. So I am going to finish off it. Now we have discussed about the initial basic ECGs under various arrhythmias, ventricular, atrial, ventricular, and nodal arrhythmias. Now I'm going to talk on conduction blocks. So conduction block at various levels: sinoatrial level and intraatrial level, atrioventricular level, and the intraventricular level. At any part of this part of the heart, that conducting system blocks, that leads to various conducting system blocks like first degree to complete heart block. So there is a delay in the transmission due to various etiologies, underlying causes. Like most common causes, MI, ischemic heart disease, and drug overdoses, toxicity, electrolyte imbalances, and collagen diseases, and fibrosis. A block is divided into first degree, second degree, and third degree heart blocks. So first degree, almost there are no symptoms, but second degree heart blocks, there will be symptoms and may go into even third degree heart block, but should be identified and treated to prevent sudden cardiac death. So in first degree heart block, the common causes are inferior wall MI, digitalis toxicity, hyperkalemia, and increased vagal tone, myocarditis, rheumatic heart diseases. So how to identify the first degree heart block? There will be a increase in the PR interval. A constant increase in the PR interval. It's a fixed increase. So that is first degree heart block. So coming to second degree heart block. In second degree heart block, there will be a block from the sinoatrial junction and at various levels. It may be 2:1 block, 3:1, 4:1 like that. Causes are like myocardial infarction, digitalis toxicity, and so this is second degree heart block, Mobich type 1 or Winkeback phenomenon. There, PR interval may be normal initially, and PR interval is increased. PR interval is more increased, and there is and followed by P wave is not followed by QRS. So one missed beat. So this is progressive increase in the PR interval followed by missed beat is called second degree heart block Winkeback phenomenon. Any ischemic heart disease or cardiac underlying cardiac disease with this may going into first degree or may go into second degree or third degree also. So it is always preferable to identify early and treat early. Second degree heart block, Mobich type 2. In Mobich type 2, there is normal QRS complex. P wave is not followed by QRS. Again, one more P wave has come, which is not followed by QRS. And then PR interval is increased. So, constant RR interval, and there are 3 P waves are there, which are not followed by QRS complex. So, this is a Mobich type 2 block, 2:1 block. Causes are same acute infection, MI, digitalis toxicity, and degenerative conduction of the conducting system. The treatment is basic. This is complete heart block or complete AV dissociation. And there is a P wave, which is not followed by QRS. And the QRS means ventricle is beating independently and atria is beating independently. And there is no relation between the atria and ventricle. So this is called complete heart block, complete AV dissociation. So coming to intraventricular blocks, in the ventricular system itself, you know that conducting system is divided into left and right bundles, bundle of His and Purkinje fibers, right bundle branch and the left bundle branch. Left is divided into again left anterior and left posterior. Any block in this system is going to right bundle branch block or left bundle branch block. Common causes are myocarditis, valvular disease, cardiomyopathy, coronary artery disease, hypertension, pulmonary artery disease, drug toxicity, and other congenital diseases. They may have symptomatic, sometimes asymptomatic, and patient will have single fascicular, bifascicular block, and trifascicular block. Trifascicular block may go into sudden complete heart block or Stokes-Adams attack. Stokes-Adams attacks means patient have a sinus arrest. So the therapy is treat the underlying cause followed by pacing if not responding. So how to identify the right bundle branch block? There will be a RSR pattern in V1 and V2. Supply the right part of the heart, right ventricle. Same causes like MI, ischemic heart disease.
David, slides not changing.
Now,
No, it's still on complete heart block.
no, madam. Change is that.
Madam, for us changing.
చేంజ్ అవుతున్నాయి మేడం.
So, in this
ఇప్పుడు
right bundle branch block, usually in the lead V1, there will be a small R and large S wave, but here it is a large R wave. That means due to right ventricular hypertrophy or right ventricular dilatation, R wave is there. R wave means it is positive impulse electricity. S wave is a negative. So when the usually normally small r and large s is there is a common ECG in the lead V1. If it is become R wave is there in the lead V1, that means there is a right bundle branch block, RBB. So once I finish the bundle branches, if the QRS pattern, broad QRS there in the anterior leads, that means the V4, V5, V6 and L1 AVL, that is left bundle branch block. We have to identify left bundle branch block and right bundle branch block. If there are left and right both are there along with the P wave variation, that means P wave is changing, PR interval is changing like first degree or Winky back like phenomenon, along with right bundle branch block and left bundle branch block, that is called high AV nodal block. They may go into sudden complete heart block. If you identify at that stage and treat that, you can save the patient to going to prevent the cardiac arrest. This is the electrodes we have to keep around the heart. So all the electrodes looking at the heart from 360 degrees angles of the limb leads and chest leads. Leads should be placed in a properly as shown here. The right one, all three limbs are positive, whereas the limb lead that can be put on the right leg is the dummy, like dummy. Oh. So, but you have to keep all these words as per the color code. Otherwise, it will give wrong placement and wrong ECG. So, this is the normal ECG. I need not explain, everybody knows, but I want to tell here which part of the leads that shows which part of the heart. So, lead L1 and AVL indicates the lateral part of the left ventricle. Lead 2, 3 and AVF, these are show the inferior part of the left ventricle, inferior wall. And lead V1, V2 are the right ventricle. V2, V3 are the septum. V3, V4, V5, V3, V4 are the anterior wall. V5, V6 is the lateral wall. So, once you see the changes in particular ECGs, at least two leads will be, changes will be there, successive two leads. So, we have to identify which part of the heart is involved and which vessel is likely to be involved depending upon the ECG lead, so that we can diagnose the patient. And if at all any doubt is there, we have to check the echo to identify regional wall motion abnormality of that particular area correlating with the ECGs. There are tremors in the, see there are the muscle tremors, patient is moving or lead is moving, muscle tremors are there. You can see this type of muscle tremors. This is artifact. And also see here like P wave is very big and P wave is inverted like thing. These are there that these are because of artifacts and the electrical impedance. So as I told, which part of the ECG leads correlate with which part of the walls of the left ventricle to identify the particular ischemia. Now I am going to start the case scenarios, and I expecting all the residents to respond. If the resident not respond, consultants also can respond to diagnose these patients. So a middle-aged patient presenting with chest pain under diaphoretic, BP is dropping to 80/50 following sublingual nitrate. Somebody given chest pain, sublingual nitrate is given, but BP is falling later. This is the ECG. What is the diagnosis? Hello? Hello? Sir, am I audible?
Yeah, you are audible. You are audible.
ఎవరు రెస్పాండ్ అవ్వట్లా, డౌట్ వచ్చింది.
Sir,
Sir,
I'm
What is the
ST
diagnosis?
elevations in inferior leads with reciprocal changes in the lateral leads.
Yes. So diagnosis is
Inferior wall MI STEMI, sir.
ST elevation, inferior wall STEMI. Okay. Because of inferior wall, you should not give sublingual nitrates unless otherwise it is proved. Because inferior wall MI, if you give nitrates, patient will go into bradycardia and hypotension. Okay. And there is a RVMI also is there because of ST elevation in the V1 and V2 lead. Then if we have ST elevation in V1 and V2, we have to take right-sided ECGs. The right-sided ECG, V4 lead R, V4R will give the confirmation of RVMI due to ST elevation in that lead. Once anybody have the ST elevation on V1 and V2, we have to check the right-sided leads, right-sided ECG. Another case, middle-aged diabetic patient presented with shortness of breath, clinical evidence of pulmonary edema, and patient is anuric. So what is the diagnosis? Patient having pulmonary edema and patient is anuric and having severe breathlessness. See the ECG and diagnose.
Sir, evolved lateral wall MI, sir.
Huh?
Evolved changes are noticed, sir. Q waves are noticed in the lateral wall, septal and lateral walls.
So actually, whenever you see the ECG, you have to check all the waves: P wave, QRS, QRS complex, QRS duration, PR interval, STT changes, and U wave, everything. Just broadly, once you see, it may give wrong interpretation. So don't diagnose immediately, and you have to check the clinical picture scenario, and then see the ECG. Okay. May looks like already Q wave there in only V2 and lead 3, right?
V4.
V2, lead 3, V2, V3, and V4 and V5 also. But what about the QT and what about the other leads? Did you check the lead L1, AVR, AVL, the inferior leads? That means the whole heart is gone into MI. Hello?
Sir,
మొత్తం హార్ట్ కి ఎంఐ ఇచ్చిందా?
అంటే ఆల్ లీడ్స్ లో ఉన్నాయి కదా సార్.
చెక్ ద కేస్ సినారియో అండ్ పేషెంట్ డయాబెటిక్, మిడిల్ ఏజ్డ్, షార్ట్నెస్ ఆఫ్ బ్రెత్, పల్మనరీ ఎడిమా, పేషెంట్ ఈజ్ ఎనూరిక్. There is no P wave. Okay. Broad QRS. See, this wave is idioventricular. Okay. Sine wave like pattern. Tall T wave. Broad QRS. So all suggestive of features of hyperkalemia. So broad Bezier complex, severe bradycardia, and no P wave, peak T wave, and rarely sine wave seen. This patient is having potassium of 7.5. So patient needs immediate correction of the hyperkalemia followed by dialysis. So another case, a 20 years old male present with seizures and hypotension. 20 young man presented with seizures with hypotension, and we took the ECG showing like this pattern. So what is the diagnosis? Hello? Suppo right ఎవరో లేదో చెప్తే then we will go to the another slide.
Sir, P waves are not seen. QRS are broadened. There is tachycardia.
Okay.
And ST changes are noticed in the lead 1. Lead 1 and AVL.
Okay. So what is the diagnosis? And there is some ST elevation in the AVR.
Yes, sir.
It is unusual in young man. And history of seizures here. See, always check the clinical correlation. You should not go jump into diagnose the ECG by looking at the ECG. Always go through the clinical presentation. Hypotension is there, broad QRS is there. So diagnosis, what you suspect at least in a young man, 20 years. Hello? What you will suspect in a young man with seizures, hypotension? Right, okay, we will go. So this is what,
చెప్పండి సార్ అది
it's all
ఏంటది సీజర్స్
seizures with hypotension, 20 years, ECG changes.
Sir, any poisoning?
Yes, it is a poisoning. Broad QRS more than 100 and the R wave, you don't see R wave in the AVR. R wave is more than 3 millimeters in the AVR, suggestive of sodium channel blockers poisoning, like tricyclic antidepressants. So ECG will be like this: broad QRS, R wave in the AVR. So another asymptomatic adult patient, routine ECG, describe the ECG. This is asymptomatic adult. Routine ECG is taken in the hospital. So what is the diagnosis? Savia, you are
Sir, P waves are seen, sir. QRS complex are normal. There are TL versions noticed in 1, 2 AVL and V1, V2, V3, V4, V4, V5. And
what is the diagnosis?
sir, this could be triple vessel disease or NSTEMI.
So that's what I am telling. You have to check all the leads with the proper lead positioning and this thing. You always see positive waves and negative waves in the AVR. Okay? All the leads become negative and negative waves become positive. Understand? So,
Yes, sir.
yeah, this is dextrocardia. There we have to keep in mind that in case of every AVR positive is not dextrocardia, if the precardial leads are normal, that means precardial leads here are negative. If the precardial leads are positive and this also positive, that means there is a wrong lead placement or lead reversal. If it is negative, all leads negative except the AVR, that is dextrocardia. So we have to differentiate whether it is wrong lead placement or dextrocardia. Okay. The middle-aged patient presenting with central chest pain. So what does this ECG shows? Middle-aged man with the central chest pain. Coming to the ER and the ER taken the ECG. Diagnosis first. Hello?
So STEMI.
What STEMI? Only STEMI, yeah? Where you see the leads and which part of the heart is involved? Is it anterior or inferior or lateral or posterior?
1, 2 and V1, V2.
Huh?
Stimulations are seen in 1, 2, AVF, lead 3, and lateral lead, sir.
Okay, diagnosis.
With ST depressions in septal leads.
Okay, diagnosis. Diagnosis చెప్పమ్మా.
Anterolateral STEMI, sir.
క్లియర్ లేదా మరి?
Sir?
ఇంటీరియర్ ఉంది కదా, యాంట్రోలేటరల్ అన్నా కదా, ఇంటీరియర్ వాళ్ళ ఎస్ట్ ఎలివేషన్ ఉంది కదా.
Yes, sir.
Inferior wall ST elevation, where you will see the reciprocal changes. Hello? If the inferior wall elevation is there, we have to see the reciprocal changes in the lateral wall, lateral leads. So there is no reciprocal changes in the lateral leads. And there is a horizontal ST depression in the lead V1, V2, V3. So whenever there is a horizontal depression in the ST depression in the lead, significant depression in the lead V2, V3, then we have to. So this is ST elevation in inferior leads, and this is inferior, posterior, lateral MI. So posterior, how do you diagnose the posterior is to have to reverse the ECG and see V2, V3. There will be like a ST elevation changes. If it is ST horizontal ST depression V2, V3, you have to reverse the paper and see ST elevation. Then it will be posterior MI, inferior MI, posterior MI, and lateral MI. Okay. Posterior lateral MI. So middle-aged female presented with dyspnea, and previously she had mastectomy of breast cancer. So presented with dyspnea, what is the diagnosis? Right. Hello. Hello.
Sir, electrical alternates.
Yes, correct. ఎవరు లేరా ఇంకా పీజీలు ఎవరు లేరా రఘు కానీ
పెరికార్డ్ ఎఫ్యూషన్
ఎస్ సార్ చెప్పారంటే ఆలోచించాలి సార్. మ్యాసివ్ పెరికార్డియల్ ఎఫ్యూజన్ ఇటు ఎలక్ట్రికల్ ఆల్టర్నేట్సెస్ మన స్మాల్ ఆర్ లార్జ్ ఆర్ స్మాల్ ఆర్ ఎవ్రీ బీట్ ఈజ్ పెరికార్డియల్ ఎఫ్యూజన్. So middle-aged patient presented with chest pain and diaphoretic. This is the ECG. Hello. Middle-aged man presented with chest pain. These are the ECG changes. What is the diagnosis? Profuse sweating. Hello.
Sir, there are ST elevations in AVR and lateral leads, sir, from V2 to V5. And there
What
is
is
ST
the
elevation
diagnosis?
in AVR. So,
Okay, diagnosis చెప్పండి తొందరగా.
పెరికార్డైటిస్ సార్.
There is a tall ST.
పెరికార్డైటిస్
Hyperacute T waves in the lead V2, V3, V4, V5. Okay. And reciprocal ST depression in the lead 3 and AVF. Minimal. But whenever a patient comes to the with chest pain with the tall tented T waves with normal potassium, this is hyperacute MI. A hyperacute MI will be like this. There won't be a much changes of ST elevation. There will be a tall tented T waves, broad T waves, and this is called evolving MI. Patient under evolving MI, we have to keep the patient in the ICU. If this is there, don't send the patient and take the ECG after 1 hour. After taking the ECG after 1 hour, there are completely evolved MI with the ST elevation in the anterior leads. So this is a anterior MI with the ST elevation. So whenever hyperacute tall T waves are there with symptoms, don't send the patient anywhere. Keep the patient in ICU. Take ECG after 1 hour, or immediately ask the cardiologist to come and see the. If you have are able to do the echo, you have to do the echo immediately to see the heart attack and send all the cardiac investigations. Frank anterolateral ST elevation. So this is young man collapsed at home apparently intoxicated. What does the ECG shows? Man collapsed at home. And what are the ECG changes?
డయాగ్నోసిస్
Sir, చెప్పండి తొందరగా. Okay, we'll go to the next. So there are giant TN versions in V2 to V6 and the marked QT prolongation. QT is prolonged very marked. Normal is less than 420. Here it is around 600. So marked QT prolongation in almost all leads with giant T wave inversion, which is called. It is because of the characteristic feature of raised intracranial pressure. This is also called cerebral T wave. This can be seen in ischemia or hemorrhage, like ischemic stroke or hemorrhagic stroke with the raised intracranial pressure. This ECG can be seen. This is called cerebral T waves. 80 years old patient with the palpitation and syncope. This is the ECG. Hello? Sir, చెప్పండి.
So third degree heart block.
Huh?
Third degree heart block, sir.
Third degree heart block.
There is a large sinus pause in between.
సైనస్ అరెస్ట్
It is called sinus arrest.
సైనస్ అరెస్ట్
Okay. 6 sinus syndrome, tachybrady syndrome. We see the tachycardia and bradycardia frequently in ECG, followed by a long pause. This is called sinus arrest. 6
సార్
sinus
స్ట్రోక్
syndrome.
అడమ్స్ ఎందుకు కాదు?
Yeah, stroke Adams also. This also can be called a stroke Adams attack. Stroke Adams attack, but this is a 6 sinus syndrome. That is called stroke Adams attack. Usually, patient will become unconscious because of long pause and have some hypoxic brain damage, followed by restoration of the ECG and hemodynamic stability. But patient will be unconscious due to hypoxic brain injury. That is called stroke Adams attack. So 30 years old patient presenting with generalized weakness. So the diagnosis, 30 years old male, generalized weakness.
Pericarditis.
Ma?
Sir, ST depressions ఉన్నాయి, sir. Almost all leads have ST depressions. So this could be pericarditis.
Clear గా చూడాలి మీరు ECG. That's why I told you every wave is important. Okay. See,
hypokalemia sir.
Yes. There is a U wave.
Hypokalemia.
There is a typical U wave before the P wave. So this is due to hypokalemia, severe hypokalemia. Long QU interval, like QT interval, there is a long QU interval and ST depression, T wave inversion, and U waves are the signs of severe hypokalemia. 70 years old patient with chest pain and dyspnea, giddiness. BP is 90/50, saturation is 83% on room air. So this is the ECG. Diagnosis.
పల్మర్ ఎంబాలిజం
ఎలా చెప్పారు సార్?
కేస్ స్టోరీ కూడా తెలిసిపోయింది.
స్టోరీ బట్టి చెప్పారు.
S1 Q3 T3 ఉంది.
S1 is there, Q3 is there, T3 is there. దానికంటే కూడా this is called subtle ST changes in the inferior lead. the
inferior leads lona subtle changes in
ST changes in the inferior leads because of strain pattern, right ventricular strain. So inverted in V1 to V4 tachycardia, subtle ST elevation in the lead 3 and AVF, and it is a reciprocal changes of RV strain. So S1 Q3 T3 pattern is there, and the history is showing, as Mohan Rao said, as an old man, hypotension, hypoxia, acute car pulmonale due to massive pulmonary embolism. Patient has embolism going into right ventricular failure. So to diagnose, we have to do the echo immediately. 90 years old patient found unconscious on the floor at home. Sir, 90 years old man found unresponsive at home on the floor. Hello? Yes, sir?
With ST elevation.
ST elevation. Bradycardia with the Osborne waves. These Osborne waves are there in all leads. Because old man had developed bradycardia, Osborne waves, and QT prolongation. It is prolonged around 600 milliseconds. So this is due to severe hypothermia. Hypothermia leads to bradycardia and long QT. 70 years old patient present with severe chest pain and diaphoretic. BP is 60/40. Sir, severe chest pain, diaphoretic, and severe hypotension. This is very important ECG. Hello? Raghu? Raghu?
sir good morning.
చెప్పు లాస్ట్ టైం చెప్పాను ఏదో చూసి నేను ఒక ఈసీజీ పంపిస్తే చెప్పాను
Sir, ST elevations in AVR V1.
Very significant finding. ST elevation in AVR, broad QRS complexes in all the leads is a significant sign of
Triple vessel disease.
disease, particularly LMC. Severe left main coronary artery insufficiency. If left main is normal, if the same type of PCG is seen in ICU, that could be due to even septic shock or severe myocardial depression due to myocarditis, due to sepsis, septic myocarditis, and even there is a compromising of the myocardial oxygen supply and demand ratio. If it is so severe in septic shock or cardiogenic shock due to myocarditis, you will see this type of ECG with normal coronary also. There is a supply demand mismatch. So broad QRS complex tachycardia can be seen in ECG with severe LV dysfunction and dilated heart. If it is the left main or cardiogenic shock, immediately you have to shift this patient to cath lab for left main opening. 20 years old patient, sudden onset of palpitation. ఏంటిది హలో రఘు
So P waves are not seen. RR intervals are regular.
No P.
Narrow. So narrow QRS complex. So this could be supraventricular tachycardia.
SVT.
SVT, sir.
Yes, very good. SVT. What SVT? Is it AVRT or AVNRT? Last class I told they have to differentiate AVRT and AVNRT. 90% of the SVT are AVNRT. అలా చెప్తారా? Or you will differentiate by looking at some changes. What you will see in the AVNRT? AVRT direct. Yeah, tell me.
Sir, AVR and V1 leads లో changes ఉంటాయి sir AVNRT.
ఏముంటాయి?
ST elevations.
ST elevation ఉంటుందా?
ST changes ఉంటాయి and Q. ST changes and Q waves.
Most
Teen versions.
Most common feature of the AVNRT is there will be a pseudo P wave and pseudo R wave. This is pseudo P wave and this is a pseudo R wave. This is pseudo R wave. Okay, and after QRS complex there is a small dip is there. So small dip is called pseudo P wave. No P wave here, but here P wave here looks like either it will be inverted or it may be small P wave like this. And then there is small S wave, pseudo S wave. It is a sign of AVNRT. Why you have to differentiate is in AVRT we should not give adenosine or chordron anything. Patient may go into suddenly bradycardia when cardiac arrest. Only AVNRT will convert with by giving adenosine or antiarrhythmic drugs. 75 years old smoker presented with acute dyspnea and productive cough. Describe the ECG. Dyspnea with cough, smoker. Case scenario. Hello?
Sir, sinus rhythm with the peaked
With the
P waves, sir. Peaked P waves.
Strain pattern ఉంది కదా?
పల్మరీ హైపర్టెన్షన్ సార్.
సార్ ఉంది ఎక్కడ?
P waves 4 ఉన్నాయి కదా?
All P waves are there.
P pulmonary. RV dilatation will be there. Chronic pulmonary hypertension.
Chronic pulmonary disease, COPD, peaked P wave more than 2.5 mm. And rightward and right axis deviation. See, AVL is inverted. See, in AVL, PQRS all are inverted due to axis deviation. Because of the COPD, lungs are bloated. The lungs are pushed the heart towards either left side or right side. So here the heart is pushed towards right side. So there is a right axis deviation with the pulmonary chronic pulmonary disease. Right axis deviation, left axis deviation, you have to identify by right axis deviation. S wave will be seen in the AVL, left axis deviation as well will be seen in the AVL. 30 years old male, Thai male. Thai male presenting with syncope. Describe the ECG. Why? Any significance of Thai male? Hello? Sir. 30 years Thai male presenting with syncope.
ST elevation.
Cocaine poisoning.
ST elevation.
V1, V2, V3.
The V1, V2, V3 ఉంది. Cocaine induced coronary spasm, sir. RSR pattern, okay.
RBB.
Brugada syndrome.
Yeah, Brugada syndrome. RBB and president syncope. This is called cowed ST elevation.
Thigh importance, sir.
Yes, sir. ఏంటి తాయి
సాయం
ఏంది పెట్టారు
మాకు
మమ్మల్ని
తెలియదు సార్. నేను తాయి మసాలా అనుకుంటారేమో.
సార్ ఇండియాలో తాయి క్వశ్చన్స్ అడగకూడదు.
తాయి మసా అయిన వెంటనే వాడికి సింకోప్
కాదు
వచ్చింది.
డేవిడ్ ఇప్పుడే ఎడికి ఎగ్జామినర్ కింద వెళ్ళొచ్చినట్లున్నాడు.
So asymptomatic 40 years old patient, describe the ECG. Asymptomatic 40 years old male.
Sir, sinus arrhythmia.
Amma? ECG
Sorry, sir. Sorry.
నీకు ఎగ్జామ్ లో ఇలా ఇచ్చేస్తే నువ్వు తక్కువ చెప్పొద్దు అలాగే. కంప్లీట్లీ చెక్ ద ఆల్ లీడ్స్, ఆల్ వేవ్స్, all means the duration of the PR interval, PRS.
Mobiles 1.
Huh? Yes. Yes. So there is a irregular narrow PRS complexes, second degree heart block. PR interval is progressively increasing, followed by beat. P wave is not followed the QRS complex. So this is Mobitz type 1 or Venkibacter. So young adult present with syncope, history of eating disorder, sudden syncope and a cardiac arrest. Right గా ఉంది కదా, క్లియర్ కట్ గా. హలో చెప్పమ్మా.
Sir, first in normal sinus low QT prolongation, sir, followed by VT.
VT కి ముందు can you identify any significant change in the ECG?
QT prolongation, sir.
So there are R on T phenomenon or R on U phenomenon. QT prolongation is there. Whenever you see the R on T phenomenon like this, so R wave is there. Sorry, T wave is there. Immediately R wave is falling onto the T wave. Because in repolarization, patient is not going into complete rest. Heart is not going to resting period, and immediately it is exciting. Immediately depolarization started. So heart is exciting due to some problem in the heart. Either it is due to ischemia or some issue, either electrolyte disturbance or something else. So heart is not going to rest, and it is exciting. Repeated excitation that leads to immediate foci of the ventricle and going into VT. Or this is because of severe hypokalemia, long QT interval with the R on T phenomenon, immediately gone into VT. And different various changes of morphology is called torsade pointers. Elderly patient presenting with chest pain, diaphoretic, describe the ECG. Hello?
Sir, ST depressions V1, V2, V3, sir.
Yes. So it shows what is the diagnosis? Yeah, it's going to finish. Yeah, tell me. Time is getting over. Raghu,
NSTEMI, sir.
Non-STMI, you are telling.
Yes, sir.
Of what?
Precordial. Is right-sided, sir.
So I told you in the previous slides, whenever there is a horizontal ST depression V2 and V3, and we have to reverse the ECG and see. This is posterior wall MI. If you feel that there is ST depression, non-ST MI, and you may misdiagnose. Actually, it is the ST elevation MI, because posterior wall is posteriorly placed. That ECG always takes negative reflection, even though it is MI. because of the reciprocal change. Because posterior wall, we cannot put the leads in the posterior behind the patient. So it always take it as a negative. You have to reverse
సార్
the
పోస్టీరియర్ పెట్టుకోవచ్చు కదా 7, 8, 9.
I cannot pick up. You have to
sir?
reverse the ECG.
అలా కాదు సార్ 7, 8, 9 మనం పెట్టుకోవచ్చు కదా లీడ్స్.
మనం లీడ్స్ ఉన్నాయి 7, 8, 9.
ఎందుకు ఉండవు?
ఎన్ని లీడ్స్ ఉంటాయి మనకి?
సార్ 7, 8, 9 మనం పెట్టొచ్చు.
వెనకాల పెట్టొచ్చు సార్, వెనకాల
వెనకాల పెట్టాలి. అప్పుడే అదే
చూడడానికి వస్తుందంటారు కదా,
అదే కన్ఫర్మేషన్.
ఏది
కన్ఫర్మేషన్ 7, 8, 9 పోస్టీరియర్ లీడ్స్ అంటాం కదా, 7, 8, 9 పెట్టాలి.
యా you can take that, but usually once you appudu the next we will take that lead, but initially if you see the ECG then you have to
first is suspicion, confirmation means by 7, 8, 9.
7, 8, 9. Yeah. So this is the reciprocal. You reverse the ECG and see this. So 16 years old male presented with syncope. They are going to finish it. Hello. So this is a short QT interval. Like long QT interval Brugada syndrome, there are some genetical abnormalities. This is called the long short QT interval. This also leads to malignant arrhythmias and sudden symptoms. 15 years old adolescent with syncopal attacks.
రెండో క్లాస్ కూడా సరిపోలేదు డేవిడ్
సార్. This is a long QT interval. Even patient with usually going to bradycardia, even patient going to tachycardia also, the QT will not change. QT will be long, more than 440.
సార్ పీవేవ్స్ ఉన్నాయా సార్ అందులో?
ఉంటుంది. The PVA is there. QT interval is prolonged.
Okay, sir.
And male, even if you do TMT also, QT will not change. Generally, if a normal patient, if you do TMT, QT will shorten, not that much, but it will come to shortening. But in Brugada, like long QT syndromes, QT will not decrease anymore. If the heart rate has gone up to 150 or 200, that is a significant sign of long QT syndrome. Middle-aged patient with syncope, dating.
Sir, ఇది బ్లాక్ సార్, హార్ట్ బ్లాక్.
Yeah, this is
complete heart block.
Complete heart block. Here, one significant thing is patient had RBB, right bundle patch block, RSR pattern is there. Okay, R become positive V1, V2, and patient had LBB, and PR interval is long. Yeah, P wave is changing, varying. So this is trifascicular block going into complete heart block. Okay, R wave is independently beating, QRS is independently beating. So bradycardia. RR is fixed interval. RR fixed, RBB, LBB, P wave is independently beating. This is complete heart block. This one. LVH pattern, stain pattern. See this V4, V5, V6 and L1 AVL. Patient is hypertensive for a long time. This is called LV stain pattern. LVH. This is
Sir, more.
Type 2 block, sir.
Yeah, type 2, Morbid's type 2. Is it? See the ventricular bigeminy between. Okay. One is P wave is PRS is the positive in the V1.
Digoxin.
Correct. So both patient had both LBP and RBP. Severe digoxin toxicity. Okay.
Sir, ఒకసారి previous ECG చూపిస్తారా sir? Sir, previous ECG ముందుది sir, ముందు. Yes, ఒక్క నిమిషం.
Mobitz type 1 and type 2 is there. It is a Mobitz type 2.
Okay sir, thank you.
అంతే కదా, ఎందుకంటే PR interval is not changing. Mobitz interval type 1 the PR interval is varying followed by missed beat. Here 2:1 block. PR interval is fixed.
సార్ ప్రెజెంటేషన్స్ రెండు షేర్ చేయండి సార్ గ్రూప్ లో.
అలాగే
బిగినింగ్ కంక్లూజన్ రెండు.
1 or 2. So here it is the LBP and RBP are there. Altering the LBP and RBP is a significant kind of severe digital toxicity. High grade AV block. Thank you.
Thank you,
sir. Hyperacute changes తో ఒక ECG పెట్టారు కదా సార్, అలాంటి టైంలో వెయిట్ చేసి థ్రాంబలైజ్ చేయాలా లేకపోతే ఇమీడియట్లీ థ్రాంబలైజ్ చేయొచ్చా సార్?
Cardiologist పిలవాలి.
Okay.
Patient symptomatic. This is called hyperacute MI.
Yes sir.
You can thrombolize, but if you wait for some half an hour, then ST elevation will be there. By the time you can send all the investigations to the echo, can call cardiologist. Patient is symptomatic. Definitely it is tall hyperacute T waves, chest pain, RWMA. It is definitely, it is a MI. Means next ECG can it will be there within half an hour. ST elevation. By the time you keep everything ready and call the cardiologist, half an hour is okay. Golden period is 1 hour kada. Hello? Golden period for thrombolysis is 1 hour.
90 minutes.
As early as possible.
60 minutes, sir. 60
So
minutes.
60 minutes sir.
అవును కదా, ఇక్కడ హాఫ్ అన్ అవర్ లో ఈసీజీ చేంజ్ అయిపోయింది కదా.
ఓకే సార్.
థ్రాంబలైజ్ ఏముంది సార్, స్టెంట్ వేస్తారు.
స్టెంట్ వేసుకోవచ్చు లేకపోతే. సరే సార్, థ్యాంక్ యూ ఆల్ ఫర్ పేషెంట్స్ లిజనింగ్ అండ్ పేషెంట్స్ రెస్పాండింగ్.
Thank you, sir.
Thank you, sir. We'll close the session today and we will meet in the next Thursday.
Thank you, David, for
Thank you, madam.
patient explaining.